Hi, everyone. We're going to start shortly. Thanks for joining. So I'm just going to mute for a little bit and then we'll start shortly. We're going to start shortly. Thanks for joining. So I'm just going to mute for a little bit and then we'll start shortly. We're going to start shortly. Thanks for joining. So I'm just going to mute for a little bit and then we'll start shortly. We're going to start shortly. Okay. Thanks for joining. I'm just going to Okay, so I got some feedback that y'all are hearing an echo. I think it might be because I'm trying to stream live on Facebook for the first time at the same time. So I got some feedback. I may have to stop one or the other. Not the Zoom. I may have to stop the Facebook at the same time. So we'll just stick to Zoom for now because I'm using the same computer. Stop one or the other. Not the Zoom. I may have to stop the Facebook at the same time. So we'll just stick to Zoom for now because I'm using the same computer. One or the other. Not the Zoom. I may have to stop the You let me know if that's better. Okay, so we're gonna wait 1 more minute and then I will start because my guest is here. So as soon as she's ready, I'm sure she's ready, but I'll just give 1 more minute and I will start. Is everybody hearing me okay? You can just do like a thumbs up in the chat if anything.
Yes, we are.
Thank you. All right. So Dr. Aimee, good evening.
Good evening. Can you hear me clearly?
Yes, I can.
Perfect.
Okay, if anybody's having any issues, you can just send a chat, a message in the chat, please. Just a few things. We, out of courtesy, of course, we would like everybody muted unless, you know, at some point we open up the floor. We would prefer that you raise your hand. I think if everybody's familiar with Zoom, if you go to reactions, you can find the raise hand button. I'm 100% sure that this is going to be very, very clear and straightforward. But for those persons who have questions, contributions, we will welcome them, but probably towards the end. I don't know if Dr. Aimee has any preference, but she will let you know as she goes through. And I realize that I've known her forever and ever and ever, but I probably will not be the best person to introduce her in terms of all of her achievements. So I'm gonna probably allow her to do that herself. But I want to say thank you very much to everybody who has taken the time to join us. This is the first of several that I'm hoping we will be able to continue to do as a St. Lucia Cancer Society. I think May has been really the month of skin cancer, but there was so much happening in May. But my general thing is it doesn't matter which month we celebrate or acknowledge it once we do. So without any further ado, let me allow and allow her to introduce herself, Dr. Natasha Aimee. Welcome.
Good evening to everyone. I'm still at work, so I haven't gone home as yet. But I'm very happy about this initiative. And I didn't even realize that I was going to be the first speaker for your series, Dr. Remy. I've been practicing dermatology for the past 4 years. I've been located in the Rodney Bay area for the last 2 years. I studied at King's College London, one of the most prestigious in the UK for dermatology. It's really my passion. I love it. I practice both cosmetic dermatology and clinical dermatology. And I'm happy, like I said, to be able to just talk about a topic which I think most of us think that it doesn't affect Black persons. So just to shed a little bit of light about skin cancer and how we could prevent skin cancer. So glad to be on board tonight.
You want me to go through the slides and put them up for you? I'm just making sure, because I know you're still at work. Just go ahead and you'll tell me what to do, or you have your own to share your screen.
No, you could go ahead and put it up, you know, because I didn't, because I was using my phone, I wasn't sure I'd be able to navigate it.
Okay, just give me 2 seconds.
Yeah.
This is what happens when you don't know how to use things. Just give me 1 second.
Always learn.
Pardon?
That's how we learn.
Yes. You let me know if you're seeing too much of my screen, eh? Are you all seeing my screen though? Are you seeing my screen yet?
No, I'm not seeing your screen. I'm only seeing the slide.
I mean, you're seeing the slide though?
Yes, just the slide I'm seeing.
Okay. Is that a good thing or bad thing?
That's a good thing.
Oh,
You said
okay.
you see everything.
That's fine. Okay, so
So we could start, yes. So we could start off with this slide. I put this slide in because just to refresh our memories for those who are medical professionals, the skin is made up of 3 layers: our epidermis, our dermis, and the subcutaneous layer. In our epidermis, we'll find our melanocytes, our corneocytes, and our keratinocytes. We know the functions of the skin, one of which is production of vitamin D. It also protects us from the external environment, be it physical or thermal. It helps with thermoregulation and also helps to prevent the loss of moisture. So the skin, the reason why I put this is so that just we familiarize ourselves, and we could have skin cancers on various levels. We have melanoma, which is from our melanocytes. We could have basal cell carcinoma forming from our basal cells, and as well as our squamous cell carcinoma. Next slide. It's important to note, I hope everybody could see this one clearly. We always refer in dermatology to Fitzpatrick scale. So the scale goes from 1 to 6, 1 being our fair skinned persons with blonde hair, blue eyes, and 6 being our dark skinned persons. And it was thought, before I used to think black skin, we just had a lot of melanin and that's what protected us. But whether we of a white race or dark colored, we all have the same amount of melanin. What differs is the type of melanin. So you could have eumelanin, which is what we'll find in our Fitzpatrick 4 to 6, and pheomelanin, which is what gives us the reddish or the whitish look in our Fitzpatrick 1 to 3. Another reason for showing this slide is because it is thought that skin cancer mostly affects persons with Fitzpatrick skin 1 to 3. But now we're seeing more and more persons are getting skin cancers in our darker skin population. One of the reasons persons in our darker skin population don't necessarily seek medical attention should they have in any form of lesions on their skin. Again, this is probably something more cultural. Persons of color, one great example is Bob Marley, who actually had skin cancer and thought it was an injury from football. So we tend, as persons of color or black skin persons, to seek medical attention when we have a skin problem very late on in the game. When it's already spread, it's very late and nothing much could be done, compared to our Caucasian or Fitzpatrick 1 to 3, who tend to always get skin checks, always are more cautious and more prone to skin cancer, so they're more aware of it. So I think a forum like this allows us to talk about skin cancer and make it a table talk now. So everybody's aware, we know that it exists, and it also exists in people of color. A lot of the things happen on a protein level. So we have a receptor called melano MC1 gene, and that will determine whether you have more eumelanin or pheomelanin. Pheomelanin, like I said, is more common in white skin. Eumelanin is more common in dark skin. And that receptor would actually tell us if we're more prone to getting skin cancer, because it would produce more eumelanin, and that gives us our dark skin population. Next slide. So a lot of the times, how do we differentiate something that's skin cancer or just a common benign skin lesions? There are so many common benign skin lesions. Next slide. So we look at things like cherry angiomas, and these are normal, these are non-cancerous, they are benign lesions. Some people have a lot on their chest mostly, and it occurs both in Black populations and white populations. Next slide. Next slide. So another popular one that we see in people of color as well is called dermatosis papulosa nigra. Common example is Morgan Freeman. We see it all the time. Most persons would come into the clinic and say, well, their grandmother had a lot of it. And a lot of people wouldn't want to take it out. They think it's their beauty mark and they love it. Some persons think it's not very attractive and like to take it out because of the way their makeup sits when they have it on. So this is very common in our population as well, very benign, nothing to worry about. Next slide. Another one is nevi, or moles as we call it in our local population. This picture is a little bit smaller, but it indicates those dark lesions that we have. So they're not as raised as our DPNs. They flat or can be raised in some instances, like a junctional nevi. So these are, again, very benign. They're melanocytic, so they have increased melanin in that area. Normally we're born with them. As we get older, we see more and more popping up. Very benign, nothing to worry about again. Next slide. Another common lesion, sorry about there's an error there, it's seborrheic keratosis. Very popular in our Caucasian group. It's called a stuck on, so it's actually looks like it's stuck onto your skin, like you took gum and you just stuck it on. Another benign lesion, and it's just a common tumor that you could see, especially in the older Caucasian group of persons, commonly on the face, the neck, the back, and even on the legs as well. So another very common lesion, like I said. Next slide. So what is skin cancer? Skin cancer is a malignant tumor, and it could be from the uncontrolled growth of any particular of the skin cells. Like I said, we could have melanoma, we could have basal cell carcinoma, and as well as squamous cell carcinoma. So these are the three big ones that we always hear about. Does skin cancer affect Black skin? Yes, it does. Skin cancer could represent only about 1 to 2% of cancers in Black. So it's rare, but it does occur. Next slide. So what causes it? Like I said, we all are protected with our melanin, and we've always known that Black skin has melanin, so we do not get skin cancers, or what would our Caucasian counterparts get. But how is skin cancer caused? So it's usually UV radiation. It's a known fact that sunlight damages our DNA. When it damages the DNA, we have what's called a P53 tumor suppressor, and that sometimes would cause the DNA to be rectified, whatever part of the DNA that got destroyed by the sunlight to be rectified. But sometimes that doesn't always work well, or there's a problem with that gene, and the rectification that should have occurred doesn't. So now we have cells that have bad DNA, and that's how our skin cancer starts off. So the damage is done by sunlight, and we're all aware of that. UVA and UVB rays can lead to skin cancers. So our next slide, please. So I said already, the common skin cancers that occur, we know melanomas. So these are the most popular ones. I decided to just focus a little bit on it. Our melanomas, our non-melanoma skin cancer. So there are two groups, melanoma and non-melanoma skin cancers, under which our non-melanoma would get basal cell carcinomas and squamous cell carcinomas. Next slide. So the melanoma, as I said previously, develops from the melanocytes, which are damaged, and there are three common types. It could resemble a mole. Most of the time, it's triggered by intense, intermittent sun exposure that leads to sunburn. So you must get sunburns, and you must get, most of the time, it would be sunburns before adolescence. So after adolescence, the incidence is lower, but once you get sunburns before adolescence, that's what leads to our skin cancers. The estimated 5-year survival rate for Blacks is only 67%, which is very important. And again, that's because we always, as a Black population, present very late in seeking medical or professional advice. And that's compared to the white population, who are always doing annual checks, checking on what's going on their skin. And they would have an estimated 5-year survival of 92%. Next slide. So this is what a lot of the times melanoma in Black skin happens in the acral region. So we would find it under the feet, the toenails. These are the places that you get melanomas in Black persons. And that's why I flipped in that slide for a particular reason, just to indicate that. So another one where we see the following slide shows again a black person and where the melanoma is found. So this is called acral lentiginous melanoma, and that's the most popular type of melanoma found in Black skin. Following slide. So again, the second or most popular type of cancers found in Black skin would be basal cell carcinoma. Again, sunlight exposure, intermittent intense exposure, and cumulative long-term exposure. So you see that even in their teens and adulthood, that exposure can lead to basal cell carcinoma. It varies in appearance. It may be lumps, it may be mixed. So there are various types of basal cell carcinoma. Most of the time, the patient will present with something that bleeds or would say it's just an irritation, a bump, or may even describe it as a pimple. I have a pimple, but it's just not going away. And they're usually painless, and that's important to note. So the patient will present with a painless lesion, most of the time on the ear, on the head, or in sun-exposed areas, so on the hands and feet as well in men. Next slide. So I have a few examples. Again, Black skin, because this is our point of interest today. Pigmented basal cell carcinoma behind the ear. And who would think nobody looks behind the ear? So that's why, again, stressing on the importance of a full skin exam, at least annually, when you see your physician to do your annual checks. This is what a basal cell carcinoma would look like. So this one looks almost like one of those I would have shown, which will be 9, and may occur a lot of the times, again, on sun-exposed areas. Following slide. So our third category is squamous cell carcinoma. Again, it's an uncontrolled growth of abnormal cells arising from the squamous cell in the epidermis. It's one of the most common skin cancers in Black persons. It varies with appearance, usually appear as a scaly, crusty, raised area. So they may occur on any of the sun-exposed areas. This is a very important point to note, that persons with squamous cell carcinomas could present as a non-healing ulcer. And in a population like ours in St. Lucia, where there's so much diabetes and chronic leg ulcer, this is where one person could present with a squamous cell carcinoma. So years and years of having a leg ulcer, and sometimes if we were to sample it or biopsy it, we would find the presence of squamous cell carcinoma. Like I said, squamous cell carcinoma, basal cell carcinoma, all be found. Sorry? So next slide.
Let me tell you something, Tenyo.
And this is
I understand sometimes we have content.
Let me just mute. If I mute everybody, I will just have to do you as well. Hold on a second.
No, exactly.
Some of them
but then you're going to Dr. Back, and Dr. Back is stressing me out.
What they do today?
Jordan.
Not sure who's, but
That's
I'm
what I'm
trying to
looking
mute
for.
everybody.
I don't expect you now.
So where him now?
You wonder what? But I cannot do a COVID test for Jordan.
Apologies, I'm trying to navigate here. Sorry, Miggy, go ahead. Let me just get this out.
You got me?
Go ahead. Let me
Okay.
just see if I can. Go ahead.
So who gets skin cancer? Like we said, Fitzpatrick persons, previous slide, sorry. Fitzpatrick 1 to 3 would get skin cancer, or more likely to get skin cancer, or have a high incidence of skin cancer. If you've had a previous history of skin cancer or any other cancers, you're at higher risk, obviously. And A family history of skin cancer puts you at risk. And of course, there are certain genetic conditions, such as melanocortin 1 receptor, like I said previously in this presentation, that has been shown to lead to skin cancers. And of course, another one I said previously would be the P53 suppressor gene that can, and in some cases, if there are any mutations in any of the genes that I just mentioned, you could get an increased incidence of skin cancer. Next slide. So how is it diagnosed? In the photo there, we see what's called a dermatoscope. That's a very instrument that we use a lot in dermatology. I attached mine to my iPhone and I'm able to see it, take pictures, show the patient the pictures. So it creates a very interactive discussion with the patients. There are certain things that we actually look for when we do our dermatoscopy. And of course, we also do skin biopsies, send it for histopathology and get our diagnosis from there. Skin biopsy being our gold standard, just to ensure a proper diagnosis. Next slide. So like we said, some of the risk factors include sun exposure, and we know the sun damages the DNA. We spoke about that. Smoking always presents a risk factor as it relates to skin cancers. The human papillomavirus, HIV infections and suppressions, anything that suppresses the immune system can lead to skin cancers as well. Of course, long-standing skin conditions like persons with ulcers or skin conditions in lupus, in lichen sclerosis, or any long-standing wound infection or wound, as in our long-term diabetic leg ulcers as well. Next slide. So what do we look for? We normally look for any lump, any nodule, any ulceration, bleeding, or any changes in a lesion. So it may have started out flat, now it's a raised lesion. It may have multiple colors in it. I always look for what we call the, oh my God, the blood vessels. So we see blood vessels running through in our nodular basal carcinoma, and I'll show you a picture in a little while. Next slide. So I said I've been practicing in this location for 2 years, so I've been seeing quite a lot of skin cancers. Obviously, 90% of what I see is in our white skin population, but there are 2 cases that really stood out, and I'd just like to talk about it. So the first case is a 58-year-old Afro-Caribbean. She had a lesion on her nose for 5 years, she said, or greater than 5 years. She was employed as an outdoor waitress, and has been in that job for over 20 years. So she's outdoors, sun exposure, one of her risk factors, sun exposure, and no use of sunscreen. So a lot of our persons who work in the hotel industries, they out there 8 hours of sun exposure and would admit to not using sunscreen, which is very important. So this is the next slide will show the lesion and my dermatoscopy. You see the lesion on her nose. It has been growing very rapidly over the last few weeks, she had said. It kept getting ulcerated, bleeding. So she did have complaints about it. And she thought it was just maybe a pimple or a blackhead she had squeezed too much, although she did admit to it being there for over 5 years. So I'm not sure what kind of pimple or blackhead stays there for that long, but she came seeking medical attention. She was referred to the surgeon, was able to excise the entire lesion with good borders. So that was a very successful story. I brought this story as well to show that as Black persons, even though we get sun exposure, or even though our job entails us to be outdoors most of the time, we still don't use sunscreen. We'd use sunscreen when I take a history from my patients. They use sunscreen at carnival or to go to the beach, but never do they use the sunscreen daily. And I think if there's one message I want everyone to take home today is the use of sunscreen every single day. Next slide. So like I said, the biopsy showed basal cell carcinoma, and she's still under treatment currently. Next slide. So this is another gentleman. He presented last year, 76 years of age. I brought this one because to just illustrate that our population is very heterogeneous. So we have lots of different melting pots, whether it be some Italian, Spanish, white, everything in one. So this is a gentleman, obviously he's St. Lucian, he's dark, but his ethnicity is a mix, one of a mixed race one. So that's the reason I brought this case in. So he was hypertensive, he had acute renal failure, he's on the regular losartan, amlodipine, and because of his acute renal issue where he was admitted once, he's on trihemic and calcium carbonate. He came in and he had the lesion on his head, and he said, you know what, it's been there because he keeps bumping his head every time he takes the bus, and it just ulcerates, it bleeds, and he wanted to know what was going on. On biopsy, we revealed squamous cell carcinoma, and he's still under treatment. He's had 2 other lesions since then. This is a man who loves carnival and gets a lot of sun exposure. Another reason for bringing this case is a lot of our young men have bald heads or keep their head bald, and there's zero protection, no sunscreen use, and lots of sun exposure. So it shows that even in our male population, we need to really take home that message about the importance of sunscreen. Next slide. So prevention, I think, is our driving message here today. Careful sun protection. Most of the times when we look, we want to ensure that it says UVA and UVB, so a broad spectrum sunscreen. We want to also do self-examination. Just like we do our breast exam, we do our skin exam and ensure that there are no lesions, there's nothing changing in shape, color, size, or evolving by any means. Again, doing photographic surveillance is always important. So I always use my cameras in my clinic, take pictures, load the pictures, so we could always have a baseline and something to compare and look forward in the near future. Next slide. So like I said, when we're choosing a sunscreen, we want to make sure it says broad spectrum. We want to look at our SPF, or sun protection factor. We always say an SPF of 30 or greater. And 30, the number 30 would represent the time we could stay out in the sun before we actually start getting sunburn. Remember, we said that sunburn is what causes our DNA to change and causes our skin cancer. Sometimes you want to look for water resistant, or I would always advise, if you're going swimming or you're out or you get wet, you need to reapply the sunscreen. Because even though it says water resistant, they are not that water resistant, and reapplying is the best way to provide the good protection. In choosing our sunscreen also, ensure that when we use our sunscreen, we always reapply after 2 hours if we get in exposure. A lot of the times I would tell persons, apply a sunscreen every morning. However, if you're going to be walking around or at the beach or getting a lot of sun exposure, after 2 hours, it's almost null and void, and you need to reapply your sunscreen. Next slide. So in our skin cancer checks, I'm not sure how well this one is being displayed. We talk about A, B, C, D, E, A being asymmetry. So if the lesion looks asymmetrical, so there's no way you could cut it and get 2 equal halves, it's a matter of concern. We also look at the borders. So if the borders are irregular, we think, okay, this is a suspicious lesion. We also look at the color. So we're looking at various colors. If it's dark, brown, black, and various colors, these are also very suspicious lesions. We look at the diameter. So we look for something that's greater than 5 millimeters would be suspicious. And we look to see if it's evolving. Has it changed anyway? Has it gotten bigger, taller, wider? Anything that is evolving would be a point of concern, especially if it's evolving very quickly. So final words before we get into a discussion and we could entertain some questions, like Tamara said. Most skin cancers can be completely cured, and that's, I think, is the beauty of skin cancers. So even though you have skin cancer, unlike some of the skin cancers that are very sinister, it's not one of the sinister ones. It can be easily cured. It could be excised completely. Though they're rare, we say skin cancers still occur in people of color or Black skin. So we want to impress on our patients, our friends, our families to take this serious, to ensure that they always wear sunscreen and do the necessary skin check. Skin cancers are less prevalent in non-white or in Black persons of color, than in the other ethnicities. And a lot of the times they are late diagnosed, and that's the problem why persons may meet their demise from skin cancer. So this is the end of the presentation. I see a hand up, so maybe we could get some contributions, questions, and have a discourse from here.
Thanks. Like I promised, it was very clear and to the point. So we will entertain the questions. I see 2 hands, so I'll try to go in order and hope that out of the numerous participants that I'll be able to get to everybody. Would you like me to stop sharing for now, or?
Yeah, we could stop sharing.
Okay, and then we'll get to the first question.
Yeah.
Arlette, I think you have a question. You can unmute.
Hi. So it says the host is not allowing people to.
Yes.
I'm being told that the host is not allowing people to unmute.
Yes.
Can you hear me?
Have the floor. Yes, we can hear you. Go ahead.
Good evening, everyone.
Good evening.
I have a question, Dr. Aimee. You mentioned the first case presentation that you have, the basal cell carcinoma lady with the. You said that her lesion was excised, good margins, and you also said though that she's still under treatment. What I'm curious.
Oh no! So no. Sorry. So she's still under the care, but this was a lesion that was recently excised. That's why I said she's still under care. Rather, yes.
Right. Okay.
So she's not under any treatment,
the treatment
because
is excision.
Excision, yes. So it was fully excised.
I was just curious. Okay.
Yeah.
Thanks.
Sorry. Yes.
All right. Thank you.
And that's important to note compared to a lot of the other cancers that we have to deal with. We always tell the patient surgeries as a part of your treatment.
That's
you need
true.
etc. So even for us as Black people, even though it's not that common, it's easier to manage. The melanomas might be a little bit different.
Difficult, yeah.
But certainly those lesions that we see all the time that look like little moles, or people take them as beauty spots, if you get them excised, you don't need the long drawn out treatments that other cancers actually require.
Except if it's late stage, and now there's so many different newer technology and newer drugs that we could actually use for like late stage cancer, like Vismuchikog and those fancy name ones.
Okay. I think we have another question from Mrs. de Tourville.
Unmute myself. We in the Caribbean. Sunshine is available. Why are so many Black people deficient in vitamin D? What's the, what's causing that?
It's because of the process of making the vitamin D. That's why we are deficient in vitamin D. That's one. The other one is because even though we are in the Caribbean, we tend to avoid the sunlight a lot, unless it's the day we go to the beach. So most of the times we walk in the shade, we keep in our office. So we are very deficient in vitamin D. Again, vitamin D has an immunology aspect to its production, and things like lupus and other autoimmune diseases, we know that there is decreased production of vitamin C in those kind of conditions. And that's why we always tend to prescribe it. But a lot of the times go ahead, thanks.
Yeah. If you have the basal cell carcinoma and that is removed, is it likely to recur?
Anytime, one of the risk factors I mentioned is a previous history of skin cancer. So if you have a history of skin cancer, you can get another skin cancer, whether it be squamous or melanoma, or you may get a recurrent of your basal cell carcinoma. Not in the same location, it may happen in another location.
Okay, thank you.
You're welcome.
Maybe you can, there's another question. Anthea? Oh, I need to ask you to unmute. Okay. Go ahead. Hi, Anthea.
Sorry, that was an error. Sorry.
Okay. I'm not sure who this person is, but the next person with their hand up can go ahead. Go ahead. We can now hear you.
Hello. Yes, I would like to know, what if the sunscreen says SPF 70 plus? Is that a good sunscreen? Thanks.
So yes, so you could get SPF 70, 100, 110. What happened a few years ago, the FDA actually put a cap on it because they reckon that after 50, it doesn't really matter. In other words, that's what the thinking is. So because persons were starting to produce 50 and 100 and 200 and 300 SPF, and it was all a big competition with the major producers of sunscreen. So the FDA actually passed a law by which after 50, it doesn't really count. However, some companies still produce the 100, the 110. And that's why. So if you get a 70, it's still good. If you have a 110, it's still good. The key, like I said, is reapplication after 2 hours. That's most important. And ensuring that it's broad spectrum, covering both UVA and UVB rays. I hope that answers the question. You're welcome.
Just one more thing. Does it have to say the word broad spectrum, or just the UVA and the UVB?
Well, no, it doesn't have to say broad spectrum, because broad spectrum is in fact UVA and UVB. That's what it means, basically.
Thank you very much. I appreciate that.
You're welcome.
If somebody is asking, are you saying that a 70 is not necessary? Or is what you're saying anything over, okay, so 50?
A 70 is not necessary.
Okay. Another question.
What the SPF means that you could stay without getting sunburn 50 minutes. That's all it means in the outdoors, as opposed to somebody who doesn't have any sunscreen on. So that's how they came up, and that was the experimental part of it.
Okay. One question asks, how does sunscreen affect the body's ability to absorb vitamin D? Does it at all?
It does. It is said to affect us. So putting on sunscreen could affect your absorption of the sun, because that's what it's supposed to do. But our main thing is to ensure that we are getting sufficient vitamin D production is being made, but we are protecting our skin from the sun.
Okay, so what's your advice on the balance of that? because I'm sure you're advocating that we should, once we're going out in the sun, which is going out, that we should wear some sunscreen. Do we save us a certain amount of time that we stay in the sun without sunscreen?
Exactly. No, I would say like avoiding the sun between 9 and 3, which we know is the most harmful rays at that point. So we could get early morning sun or late evening sun as well. So we can get some level of sun protection.
I was gonna ask a question concerning, I don't see as many albinos in Nigeria, but I think maybe we can talk a little bit about albinos and maybe the difference and the things that they're exposed to.
Yes. So I meant to talk about that actually, and it probably missed me. But we as albinos are known to have lots of squamous cell carcinoma. Again, I think we came from a culture where we didn't put on sunscreen and we didn't even consider albinos and their level of protection. So we are seeing an increased incidence in our albino population with squamous cell carcinoma. The other thing is I think one of the questions I was supposed to answer was in children. So there are particular syndromes like XP or xerosa pigmentosum, where we get increased skin cancers in children. So as young as 9 or even 5 years, they start to get skin cancer. So those children have to be protected. Again, this is more of a genetic defect, and it's seen more in our Caucasian population, but it's seen in persons of Indian and Latino as well. So protecting the skin in even our children, and even if we start ensuring that our children wear sunscreen when they get to adolescence or early adulthood, it will be part of them. They would always want to put on their sunscreen and protect their skin. We also note, I mean, from the time we were in school, Tamara, we know about the ozone layer is being depleted and all of those things. So we are closer to the equator, and the closer you are to the equator, the more harmful the sun rays are. So ensuring that our children and, like I said, our family puts on sunscreen as well.
Okay. Because I think you did mention that sunburn before adolescence is very, I guess, high or strong risk factor.
Higher risk factor, yes.
Right. So you may be doing everything as you get older, but the damage done during adolescence
already
was greatly inflict. Okay. I see that there's one more question. What would you recommend if sunscreen aggravates one's eczema?
Oh yeah, so it can, depending, I would say use maybe a mineral sunscreen instead of those with the avobenzone and those other chemical sunscreens. So using like a zinc would be better for persons with eczema. That's one of the things I recommend for eczema patients. Some of the sunscreen have a lot of irritants, could have a lot of irritants in it. So sometimes getting one that's less irritating in terms of persons with eczema is very important. We find sometimes the avobenzene is some persons may be allergic. So like I said, mineral-based sunscreen is very good in that population.
And do we have those available here in St. Lucia? Or did that have to be prescribed?
No, we do, or sometimes I find a lot of the times all we have is Neutrogena that you could find, and it's very hard to find mineral-based, but you could find it on Amazon. I sometimes carry a mineral-based sunscreen in my office if persons wanted to purchase.
Okay. So on a different note, still related to skin cancers, what we found when we collected the data on cancers in St. Lucia, although we haven't been able to do a very detailed analysis of it, was that skin cancer was one of the top 5 in St. Lucia. And of course, this kind of follows what we see globally, that is extremely common. Things like the basal cell and squamous cell as very small lesions. But as you were suggesting, it's probably persons of mixed race rather than a lot of our pure black persons, right? So would you say, I know that your first slide said that it occurs or it makes up or accounts for 1 to 2% of cancers in Blacks.
Mhm.
Other things take precedence, but
Yeah.
your experience, let's just say does it follow it according to your figures that you see in your office that it's
Mhm.
maybe mixed, and if you had 100 people, it would just be 1 or 2 that are actually Black persons?
Mhm.
Would you
Yes.
agree
Oh,
with that?
yeah, certainly. So when I see the patient, a lot of the patients that I see with skin cancer, which is like every week, would be those who've been in St. Lucia over 30 years. And back then, so 30 years ago was what, like in the 80s? The yacht club was very, for those who have aged, the yacht club was the place for them to be, and they stayed out all day in the sun. They were sun worshippers then. Again, the knowledge wasn't there, the evidence wasn't quite clear as yet on skin cancers. And of course, the incidence was a lot lower. So back in the days, persons really worshiped the sun. So I'm seeing a lot of the expat population, they've been here 30, 40 years, and these are the persons that are coming with the skin cancers. A lot of them are still not diligent or keeping on their sunscreen or compliant with sunscreen. So these are those I will be seeing with skin cancers. I am now seeing lots of Black persons or persons of color, persons like us coming in and saying, okay, I want a skin check. Or if sometimes they may come just for acne and I'm like, okay, let's do a skin check. And that's how I may see some a lesion, a suspicious lesion, and we may just do a biopsy and it comes out as something. So I get like pretty melanoma kind of, well, not pre-melanoma, but dysplastic nevi rather, because there's a thing called pre-melanoma. Yeah.
Is there a difference between sunscreen and sunblock?
No, it's the same.
Okay.
Some people say sunblock, some people say sunscreen. So, yeah.
Okay. And out of the 3 main ones that you mentioned, the malignant melanoma, basal cell, and squamous, which one is the most common in Black people in your experience? Which of those?
I would say squamous cell carcinoma. These, because of our high risk of, our high incidence of diabetic foot ulcers that go on for like years and years and years. So these are the things that we see more commonly.
Okay. I see that we have a few questions on vitamin D. So what is the recommendation? It seems to be part of lots of conversations, right? Vitamin D for everything. So what is the recommendation for vitamin D supplementation, especially for people with low immunity? That's a very general question. I don't even know the answer to that. I don't know if any of the physicians in the group might be able to add, because I don't want to put you on the spot here, because that's just very general. So if there are
it is a big,
right. And like you said, a lot of our people don't go in the sun. So while the sun is there to provide or help with the processing and the use of the vitamin D, we still have a lot of supplementation being necessary in our population. So, but luckily there are tests which you can do to check your vitamin D level. So while the same way when you go to your general practitioner for your annual checkup, I think we should all be insisting on a skin check, as uncommon as skin cancer might be for us as Black people. We may now, especially our age group, we're still young, so we didn't use a lot of sunscreen when we were adolescents. So now would be the time, kind of when we might be seeing the effects. So vitamin D measurements should probably or could probably be incorporated into our annual blood tests when we go to get checked. I don't know if do you do that like regularly for your patients who come in with skin cancers? Is there any rule for checking their vitamin D levels?
I don't normally do vitamin D checkups for patients, but I do recommend that they take vitamin D in some instances. I know for lupus, we always give vitamin D. Well, that's one of the conditions I always prescribe vitamin D as well. Just because sun could aggravate the lupus, so you really want good sun protection and avoidance of sun in our lupus patients. So we do like 1,000, 2,000 IU.
Okay. Would you advocate for the use of sunscreen in our schools as part of what our kids should be?
Oh yeah, I think that'd be a good drive on your part, just the education of use of sunscreen. Like, I think if we start from young and get that into their DNA, then it will be a lot easier as they get older.
Okay. Does anybody else have any questions or comments that they'd like to add? I know that trying to get my daughter to put on sunscreen is a task. Again, probably not accustomed to it. When she was younger, I would have no choice. She would have no choice.
Yeah, exactly. But now
now as they get older, it's like, but I have black skin, so it's supposed to protect me. So I totally agree that the educational part is necessary, like for everything else. But we just need to kind of add this to the conversation to protect our kids.
Yep.
Okay, so does anybody have any comments before we wrap up? It's just about an hour. I don't like doing things for too long, although it's very, very interesting topic, and to kind of clear the air on things that affect us here in the Caribbean. I see somebody has put in the chat.
Okay, nice stuff.
Glass, Azealia, thank you very much. The recommended dietary allowances. So everybody can probably take a look at this and see where you fit in. Let me look for the under 50 for me. Under 50. Yeah, I like that. I like that age range, 19 to 50. That suits me.
That's a wide age range, yes.
I fit in there. You can just guess where that's going. So a couple of, go ahead.
No, I think skin cancer is such a wide topic. So I try to like really narrow it and try and skim on the top layer really and truly, and just to make it a topic of discussion, so we could have had some level of discourse on it, but it is like a big topic by itself.
Exactly. So I'll allow you to wrap up in terms of what you think are the salient points as Black people that, we should take from this. Are we dispelling the notion that skin cancer, you say it's rare, it's uncommon, so should we be worried about it? It's easy to treat in the early stages, should we be worried about it? It's not the thing that's glaring at you when you talk about breast cancer, when you talk about all those other things that make you scared, just fearful just from the mention of the word. So what are your take-home points or what would you like us to leave with?
So one of the things, I think if we get a high level of exposure, so whether like the one I presented, she worked in a restaurant, an outdoor dining restaurant, that's important. Construction workers, people who do roofing, these are the people, we have quite a few persons who do sailing tours, like getting that message out to them and the importance of sunscreen in that high risk population, because we know it's proven that sun damage is what causes skin cancer in most of the cases, apart from the few that are actually genetic defects. And of course, our second point that I'd really drive home is that we should all start using a sunscreen, using it on a daily basis. So after we've cleansed our face, our body, we need to moisturize and put on our sunscreen. So sunscreen is always the last thing. If we having a weekend on the boat or weekend on the beach, because it's COVID, people are not traveling, so more people are doing staycations or things at home or enjoying the country by itself. So trying to always wear sunscreen. And a big part of it is not reapplying. So persons will be like, yeah, I use sunscreen every day, but they're in the sun for 8 hours, and after 2 hours it's null and void. So it might as well not have had sunscreen place. So I think that's a very important point to drive home. And I just want to thank you for inviting me. Oh yes, and farmers too. Dr. Parry said the farmers. So these are at-risk population. It's not those who have the marketing job indoors, those accountants who are just in an office job. So these are the people I think we really, really need to reach right now.
Before you say thank you again, I know that one of the campaigns that we see for prevention or, you know, awareness of skin cancers always include, as Dr. Paris said, the nice wide brim
hats.
And even as much as it seems against what we were taught when we were growing up, covering up. So we tend to think that going to the beach and wearing the skimpiest, yes, you can have on the sunscreen, but actually wearing some long sleeve stuff when you're out actually helps, right? Eyewear, I know we didn't touch too much on that in the sun, but in general, if you're going to be out in the sun, then you need to protect everything. So the advice would be wearing shades to protect the eyes, wearing wide brim hats, wearing the sunscreen, of course, and as much as possible, wearing sleeved clothes. It may seem contradictory, out in the sun, you're gonna sweat, but you're still protecting portions of the body that are exposed. And perhaps with climate change and everything else that's going on, we may actually see increases in cancers in Black people as time goes on. And it's not gonna happen right now. We'll see it when we are 60 and 70 if we continue not to take care of our skin. Yeah.
Well said. Well said.
All right. Well, since there are no more questions, I would really like to thank you, Miggy, Dr. St. Aimee.
That's fine, Miggy, yes.
for you know, agreeing to participate in this. And I'm sure that there'll be lots of questions and lots more opportunities to have you join us. We've learned a lot, and I think a lot of the take-home points will be taken home. So everyone, we should be educating our kids, putting on the sunscreen, and doing our part to maintain our flawless skin. The skin is what we're born with, and when we're born, it's really pretty. So, you know, we don't want to get the blemishes and we're set the cancers that come with just not taking care. So thanks again, and thanks to everybody who took time to join us. Continue to stay tuned, and we will continue to have many more of these cancer topics, which are not too scary, that we can have the conversation. And feel free to message us. And if you have any questions, we will pass them on to Dr. St. Aimee and get right back to you. So thanks again to everybody for joining. Thank you.
Thank you. Great job, Tamara. Bye-bye.
Bye. Thanks, everybody.